Good evening, friends. You all are welcome to this webinar, and I'm sure that you all are safe in this prevalent COVID condition. Today, this seminar is focused on the degenerative knee disease and the most advanced technology and the techniques to treat that osteoarthritis knee. So we have Dr. Kunal Shah with us today for this discussion, and I'm sure that we all know about him. He's not an unknown name of the city. He is a very well-known orthopedic surgeon of the town, and his father, Dr. Ajay Shah, is a very well-established and very well-known popular orthopedic surgeon of this city. So Kunal sir is discussing today about the most advanced technology for treating the osteoarthritis knee, that is a unicondylar knee replacement. But before we start, it is worth that we introduce him in proper way so that we know that how he has achieved this big technology in his cap. So Dr. Kunal Shah is an orthopedic surgeon, and he did his MBBS from the Pramukh Swami Medical College, Karamsad. Even the primary training, I mean the basic training of orthopedics he has taken from same college. He has taken his advanced orthopedic training from Ganga Hospital, Coimbatore, and then he followed his fellowship in joint replacement from Germany. So after finishing this big study, he has joined his father because it's a very well-established hospital, and he has joined that hospital, Ashutosh Orthopedic Hospital, which was earlier at the Jetalpur Road, but now it is operational since few years with the most modern setup at Akshar Chowk, Munjmauda. He is chiefly interested in complex trauma and replacement surgery, joint replacement surgeries, and he has treated hundreds of patients successfully. And I think we all know about him because one or the other way we have treated his surgical cases successfully in our setup also. So we all know about him. So today he is with us and he will discuss all the things with us. I hope that you will enjoy this session. Before we start, I would love to mention that we'll keep our all videos and audios mute for the smooth operation of this webinar so that it will not come in the way. And also we have kept the question and answer sessions. So who have question and answer questions arises during this session, so keep in mind and just post it into the chat box of this webinar so that later on we will have this session of question and answer, and Dr. Kunal will answer the questions whatever you have. So without wasting much time, we are now starting. I will request Dr. Kunal sir to continue with this. Thank you so much.
Thank you, Snehal bhai. That was a great introduction that you gave. I don't deserve that much, but thank you so much. Thank you. So I would first say that I hope all of you are keeping safe and doing well. I mean, I know it's difficult times, but yeah, I was always planning to do this thing, meet with the physiotherapist, but somehow or the other, this never happened, and now I am here doing a webinar. So yes, that is there. Now I would like to talk about all the treatment modalities in general and partial knee replacement in particular, how we can move around it. And we all know that knee pain is one of the most common things that as maybe physiotherapists who are treating ortho patients and orthopedic surgeons in general do face. And arthritis, as we all know, in winters and monsoons, when they start, the symptoms are much more. So yes, I'll start with my presentation. Okay, you can all see my presentation?
Yes, sir.
Sir, visible, sir. Oh, done. All set.
Yes, sir.
Right. Okay. So, all right. So I think now we can just pull off the other videos and I will just start my presentation. Okay, so already Snehal Bhai has introduced, so I won't go there. Knee arthritis. Now, knee arthritis, as we all know, is a very common problem, and it starts in the middle age and progresses over a period of years. I would request everybody to just put off their videos. Even the co-host can just put off their videos, so that would be good. There are basically 3 stages here. In the initial stage, when the symptoms just begin, they are on and off. Then there is the intermediate stage where the symptoms are, the frequency is more, the intensity is more. And then when it progresses, it goes into the advanced stage. As we all know, initially we will all treat them with good physiotherapy, muscle rehab, we'll give them analgesics. Now, from the surgical point of view, I can say that not just surgery, but in the early and the intermediate stage, we can always, try and delay the progression of arthritis, and that remains very important so that they don't go to the advanced stage and then require knee replacements. So, if we treat them at the right stage, we can definitely delay or avoid surgeries in these patients. So, 3 basic concepts of treating arthritis. First is regeneration, where you try and regenerate the cartilage that is damaged. Second is reconstruction, where you are trying to, change the alignment of the knee and, address the issue which caused the arthritis, like varus. And the third modality is when it is advanced to a stage where you need to replace the joint. Now, in regeneration, basically we are looking at the use of platelet-rich plasma and stem cells. Reconstruction involves correction of the mechanical malalignment in deformed knees. And replacement involves either partial or total knee replacements. And we all know that regeneration is definitely better than reconstruction, and it is definitely, both are better than replacements. This is a short video of how a platelet-rich plasma is, how we take out and manufacture the platelet-rich plasma. Basically, you take out 30 ml of blood and then centrifuge it. So what remains is platelet concentrate. This is done in the outside department. And then you have to inject it in the artery. It takes about 20 minutes. From the patient's blood, and you can inject it into the joint, and the patient can go home in the next hour. So what are the advantages? So the basic advantages are that it is a very quick procedure, no admission, so very low cost. There are no side effects like when you are using steroids, you end up having side effects of infection, etc. So all those side effects are not there. Patient's own blood is used, so no chances of allergy. And also the thing is that in unresponsive chronic pain and injuries, muscle injuries, it definitely works very well. And it also decreases the osteoarthritic symptoms of pain and stiffness once the cartilage starts to heal. Now, this is reconstruction, high tibial osteotomy, as a lot of you might be aware, where you are trying to correct the mechanical axis of the joint. So basically, you can see in the diagram that there is varus progressive varus, which is corrected by making a wedge and opening that wedge and then fixing it with a plate. So the mechanical axis changes and the weight is borne in the center of the joint as compared to the medial compartment. This is how it looks pre and post-op. So again, this is a short video on how it works. Basically, we are shifting the weight bearing activity. Now, what are the advantages? Advantages are it retains the original bone and cartilage, and since the mechanical alignment is corrected, the patient starts to experience relief from the joint pain. It increases the joint life, and later on, if required, we can convert it into a total knee replacement. Now, joint replacement, that is when the knee has advanced, the arthritis is advanced enough that none of these can work. So now, initially we were always thinking about total knee replacement, but partial knee replacement, which I'm going to talk about, works wonders in a lot of these patients. Now, the indications for both remain the same, and this is very important to understand, because it is not that a patient who will require a partial knee is different from the one who requires a total knee. So these are basic symptoms which can indicate that the patient will need surgery. If the patient has daily pain, if the pain restricts his activities and enjoyments in life, if the patient tends to avoid going out and there is a lot of restriction of his day-to-day activities, they cannot exercise, especially obese diabetic patients who are not able to exercise, then just because of knee pain, then those are very indicated patients for joint replacement. And for patients who really experience that their world has become smaller, and this is a lot of in this age we see a lot of patients who want to do a lot, who want to travel, because say they are 60, 65, they want to go around the world, they want to travel, do their normal recreational activities, and just because of arthritis they are not able to do that. And that is also again an indication that they should undergo joint replacement. Now, what is partial knee replacement? Now, partial knee replacement or unicondylar knee replacement means only a portion of the knee is resurfaced. Now, normally, as we know, in a total knee replacement, both medial lateral femoral condyles and medial and lateral tibia are replaced. Here, only the affected joint is replaced, and in 95% of the cases, in varus knees, it is mainly the medial tibial condyle and the medial femoral condyle, that is the medial compartment, that is affected. Now, the whole concept is born out of the fact that these partial knee replacement, the main aim is to reproduce the meniscal function by making a fully congruous contact, having mobility at that joint, and having a compliance. That means it can, yield and modify itself to the stress of flexion, extension, etc. The whole idea is, in a partial knee replacement, you can keep 75% of your healthy knee. Now, the classical indication is anteromedial osteoarthritis. Now, the term seems pretty complex, but if you look at all your arthritic patients, most of at least Indian patients will have osteoarthritis as compared to rheumatoid or other systemic arthritis, and these osteoarthritic patients will have varus. Now, in a varus osteoarthritis, it begins in the anteromedial compartment, and 35 to 40% of these patients are patients who have anteromedial osteoarthritis. The posteromedial part, as well as the lateral compartment and the patellofemoral compartment, are reasonably good. So the whole idea is that the ligaments are intact, functionally normal. They don't need to be anatomically perfect, but they are functionally normal. And the criteria for diagnosing this is very simple. On an X-ray, we can easily make out whether this patient has just anteromedial osteoarthritis or has a progression of the arthritis into a tricompartmental disease. So it is medial osteoarthritis with bone on bone. This is on the X-ray. We can make out whether the functionally intact and there is full thickness cartilage in the lateral compartment. It is demonstrated only on X-rays. We don't need to do an MRI to diagnose whether the ACL or the MCL is doing well. So again, if you look at this picture, you might see that it looks really bad. You can think that this, this is a bad knee. But only if you see the medial femoral, medial tibial compartment are damaged. This is mild fibrillation of the cartilage here. It is okay, all good. This doesn't need to be replaced. Same goes, you can see an intact ACL here. This is the ACL. ACL is intact. The patella seems pretty good. Now, what happens is these patients do very well with just a unicompartmental knee arthritis, and they do very well with a partial knee. So they don't need replacement of the intact good lateral cartilage, the patella, and the lateral tibial condyle. And this is a classical cut of a partial knee replacement. You can see that the posterior cartilage here is always intact because it is an anteromedial arthritis. Now, again, we discuss about HTO. This is a classical case. If you see the figure on your left, this is bone on bone, where the bone is touching the bone. So this patient has anteromedial arthritis. Whereas if you see here, the figure on the right, there is some space between the femur and the tibia. That means the meniscus is still there and the damage hasn't progressed. There is just mechanical malalignment. So this is partial thickness loss, and these patients, the one on the right, do well with an HTO, whereas the patients like the one on the left do very well with a partial knee replacement. Again, if you see this is a spectrum. So the same patient, the one on the right, will progress to this if we don't act in this stage. So eventually, if you get them early, you do an HTO, they will do well. But if they progress to bone on bone, you should not consider an HTO, you should do a partial knee replacement. And again, if these patients at this stage are not treated, they will progress to a tricompartmental disease where the lateral compartment will also get involved and the patellofemoral will also get involved, and then they definitely need a total knee replacement. So these are variations of anteromedial arthritis. If you see the first figure, hardly 30% of cartilage loss. Here you can say about 65 to 70%, and here 80 to 85% cartilage is gone. All these can do very well with a partial knee replacement. As long as the posteromedial cartilage, this cartilage is intact, even 20% cartilage is intact, they do very well with a partial knee replacement. And this is a diagnostic aid where you are supposed to take 5 x-rays. So a standing AP view, a lateral view, varus stress, valgus stress, and a skyline view. Just these 5 x-rays, and there are specific criteria in this decision aid, which can make you confirm whether the patient is a candidate for partial knee replacement or a total knee replacement. And this is not something that is untested or something new in the market where you can think that this has come and this will go away. Like a lot of things that happen, like robotic surgeries, they come, they go, then they change, they come back. Then there is the gold knee. A lot of things come up and go. This technology has been there since 1976. And the good part is that since 1976, the articulation has remained unchanged. That means the success is pretty high. Now, someone might wonder why it has not why it has not been popular. So there are a lot of causes. One, a very important cause is that it is very technique dependent. So it requires a lot of precision. And so not everybody who has not learned it or who has not practiced it enough can perform it and give very good successful outcome. The second part why it has not been popular is because the market dynamics have been such. The company itself has not always been very prevalent in India. And so the implants also do not come. And so the technology, once the technology doesn't come, the learning curve is always a problem. This is a small video of how anteromedial arthritis is. You can see the diseased femoral condyle. It is the medial femoral condyle, and once you replace it, you get almost normal range of movement and a very natural feel. And I will come to this point. So when we compare a total knee and a partial knee, a lot more bone is removed in a total knee. As I told you, about 75% more bone is removed. More importantly, the anterior and in most cases, even the posterior cruciate ligaments are removed. The medial collateral ligament also has to be released when we are doing a total knee. Whereas in a partial knee, both the ligaments are retained. We don't need to even see the medial collateral ligament. So very less tissue damage. Now you can see here how much bone is removed, and you can see that the whole lateral femoral condyle, a part of the medial femoral condyle, everything remains the same. The tibia, the same thing goes with the tibia. All of this remains intact. So in a total knee, because we are removing a lot of bone, we have to take care of the patella also, and hence a lot of cases also require patellar resurfacing. Now the advantages, as I told you, it has a higher range of motion, it is bone preserving, lesser pain and easier physiotherapy and rehabilitation. It is minimally invasive, the recovery is definitely faster and lesser complications because of all of the above, because there is lesser soft tissue damage, lesser invasive, it is a less invasive surgery. So the complications are also much lesser. And you have to see it to believe it. I mean, a lot of our patients, even our physiotherapists tell us that a lot of patients who have undergone partial knee replacement undergo very quick rehab or very quick, they are back to normal very quickly as compared to a patient who has undergone a total knee replacement. And most importantly, as physiotherapists, you all would have felt some of your patients whom you are treating after total knee replacement. And it has happened to us as well, that some of our patients are not very happy after they get a total knee. And that is there all over the world. There is a certain dissatisfaction rate after a total knee replacement. And that is mainly because the patient feels that there is something that is not natural in the knee. And usually it is because the soft tissue tensions have altered, the ligaments are not there, it is artificially balanced. And hence, a lot of these patients feel that there is not a natural feeling. Whereas in a partial knee, they definitely have a very natural feel of their knee. Now, if we look at the complications, lateral compartment arthritis, and a lot of people think that what would happen to the lateral compartment, but there are a lot of studies which say that even over a period of 28 years, the arthritis is just about 2.3%, which is very less. The other worry is infection, which is less than 1%. Loosening, again, very less. Over a period of 28 years, there is less than 2% chances of loosening. And patellofemoral problems. So when we look at the X-ray, sometimes we see a minimal osteophyte in the patella, but if you look at them clinically, they don't have any problems. And after undergoing a partial knee replacement. So there are no revision cases for patellofemoral problems after the partial knee replacement. There are some common misconceptions and around this surgery, and I would like to clear that some people feel it is a stopgap arrangement. એટલે ગુજરાતીમાં કહું તો એવું લાગે કે ભાઈ અત્યારે શરૂઆત છે તો આ કરાવી લો, પછી વધશે ત્યારે પેલું ટોટલ નહીં કરાવીશું. But that is not true. It is a definitive solution, and the thing is that the life of the partial knee joint is as much as a total knee joint. So it is not a stopgap arrangement where you are waiting for the other compartment to develop arthritis. Okay, it is not a stopgap arrangement. Second, that it is suitable for the young patient. That if the patient is young, then it makes more sense to do a partial knee. Actually, this is again absolutely not true. It is ideally the other way around. What happens is that if a patient who has a very good lateral compartment and patellofemoral compartment, say at the age of 70 years, then this is the best surgery for him. Just think that the patient has been active all these years and he or she hasn't developed arthritis in the lateral compartment. What are the chances he will develop arthritis in the next 10 to 15 years until he lives? So these patients just need a partial knee replacement, and they are the ideal patients. Their compartment functioned very well all these 70 years or 65 years. And again, the requirement is again going to be, it is going to get less as they get older. The complication rates are much lower as compared to a total knee. So a partial knee replacement actually is ideal in the elderly age group. And again, some people feel that it can be used as an alternative to high tibial osteotomy. But as I said, the indications are totally different. High tibial osteotomy is preferred, in a youngish patient who doesn't have bone-on-bone disease. Once there is bone-on-bone disease, you have to think about joint replacement. Now again, all surgeries cannot be done in all patients, and there are definitive contraindications for partial knee replacement. So advanced osteoarthritis, once there is severe osteoarthritis involving the lateral compartment, patellofemoral compartment, then they cannot just be treated with a unicondylar knee replacement. Rheumatoid or systemic arthritis. Okay, so patients with rheumatoid arthritis will have involvement of the whole joint. Synovial inflammation will be there, and they will progress to systemic joint disease, and hence a total knee replacement is the solution for these kind of patients. Post-traumatic arthritis, where you are looking at times when there has been an injury, a tibial condyle fracture, and then they develop arthritis. These patients have deformed axis which cannot be corrected by a partial knee, and so then they will require a complex total knee replacement device. Sometimes they also require intramedullary rods in the femur and the tibia. That cannot be done with a partial knee replacement. Again, people who have a ACL post, sometimes patients have an ACL rupture or an ACL insufficiency, sometimes an MCL rupture because of an old injury. And then if there is ACL or MCL injury, then the arthritis will progress to the lateral compartment. So definitely then they should undergo total knee replacement, and a partial knee replacement should not be done in such cases. And I'll also show you some results of our surgeries. This is the left knee that has been operated. The pre-op is on the left side and the right side shows the left knee that has been operated. You can see the scar is pretty small. This is the walking video at 1 month. Very difficult to differentiate which knee has been operated. And he underwent bilateral partial knee replacement. So again, this patient, you can see this patient, this is second post-operative day in the hospital. She's able to flex her knee up to 100 degrees. She's able to even, sit cross-legged on the bed just in the hospital after 2 days. Walking videos of the same lady. Again, these videos are taken at the end of the first one. She also has both knee that are affected, and if you see, after operating the left knee, she needs to take support on the right side. So the left knee has become very asymptomatic. So if your patient has been advised total knee replacement, you yourself can evaluate the patient. It can be done on a basic X-ray, and you should always discuss about the option of a partial knee replacement. So this is one very interesting case. This lady had got a shaft femur fracture. You can see in the pre-op X-ray. She had a shaft femur fracture with an intramedullary rod that was doing very well. Now she developed arthritis, and you can see this is bone-on-bone disease here. And so if I had to do a total knee for her, I would have had to do 2 surgeries, remove that rod again, and then do a second stage total knee. But we just did a partial knee and she is doing very well. She is now about 2.5 years follow-up. Thank you. Stop my screen sharing. Yes, Nehal bhai.
Yes.
I hope I was clear.
Yeah, it was a good conversation and good presentation, right, Tadar? Anybody in the participants group, any questions, can go to the chat box and can type it and post it.
I'm seeing some questions here.
Yes, sir.
Yeah.
Okay, so would you recommend partial knee replacement of patient with chondromalacia patella with AMOA? Do you think with such patients would benefit with this procedure? Yes, this is an interesting question asked by Dr. Tushara. Yes, chondromalacia patella is usually, you have to evaluate it. If they just have, stage 1 or stage 2 with cartilage fibrillation, then they are okay. They are good cases for partial knee replacement. But if the patella has it is advanced from chondromalacia to arthritic stage, where the patella is really starting to degenerate, then these patients are not a good candidate for partial knee replacement. We have definitely operated on patients who have not been having a totally very good patella. But what we do is we just cauterize the edges of the patella, remove the osteophytes, and it has over a period of years we have seen that they do very well. And even I had spoken to the designer surgeons at Oxford. So they also do recommend that in early stage of patellar arthritis, you just do what you call is if you just remove the osteophytes, you cauterize the patella, and then we file the surface of the cartilage, which is rough, and then it becomes smooth, and then it does well over the years. Main thing is if they have some malalignment or some muscle or soft tissue imbalance that has caused this thing, that has to be addressed for sure. That you cannot leave it that way. If there is some muscle imbalance causing patellar issues. I can see some more questions.
There are 2 more questions.
Yeah. So one is okay. So this is an interesting question by Dr. Salami, that if they have got a TKR on one side and they need another surgery. So I have faced this question myself because I started doing a partial knee replacement since the last 2.5 years, and a lot of our patients have already got a total knee on the other side. And yes, if I do give them an option of doing a partial knee, and a lot of them have agreed and trusted us, and they have done very well. And that has actually been the best study for me, because a patient who has undergone a total knee on one side and undergoes a partial knee on the other side from the same surgeon in the same setup, and if they tell you that the one in they are rehabilitating much faster with a partial knee than than the total knee, then you are very confident that yes, this is the right example, and definitely the results are good. Rather than comparing 2 different patients, if you compare the 2 different legs of the same patient operated by you yourself, then you are pretty confident that no, the thing is doing well. So yes, we have had some patients who have undergone partial knee on one side and total knee on the other side. And we can do that. That is not a problem.
Is there any limb discrepancy issues in such cases?
No, not as such. No limb. Actually, I'll just show you the models as well. There is very little bone removed. Okay, and
right.
Unless there is gross varus, where you have shortening because of the varus, but then again, those candidates where there is advanced, arthritis and gross varus, they need a total knee replacement. They are not the right candidates for partial. But per se, once there is no limb discrepancy issue, even after a total knee, unless there is a lot of bone loss or something, you might experience say 4 to 5 mm of difference, not more. Because we build up bone, even in a total knee, we build up the bone because we have to balance the patella and everything, the ligaments. You can't kind of go along. So there is something, those inserts that they come in 2 mm increments. So yes, from 2 to 4 mm to a maximum of 6 mm change can be there. But 6 mm is hardly noticeable. Even if we go to that extent, 6 mm of limb length discrepancy is hardly noticeable, and most of them have varus in the other knee as well. So a lot of these things.
But there is one question. There is a second question on the top.
Okay.
If any patient's gone through PKR and after a few years, if he or she have problem over lateral and patellofemoral arthritis, then what will you suggest?
Okay, so luckily, it's only 2.5 years since I have been doing them, but I have spoken to a lot of people, and the place where I train, they do a lot of revisions of partial knee as well. But you have to understand that a revision of a partial knee is much easier than revising a total knee, because I'll explain in the model itself, because a lot of your bone is native, so you don't need to change that. And the cause of revision in a partial knee is usually very rarely if they have some injury or they have something which causes fracture or loosening of the joint, rather than them developing lateral compartment arthritis. And as I showed in that study, those are less than 2% over over 20-year period. So unless you have not done the surgery very well and you have overstuffed the medial compartment, then there is a problem. But if there is a partial knee can definitely be revised into a total knee replacement very easily. It is not something that is a big problem per se.
So mostly the revision would be PKR and not always a TKR. Okay?
No. Partial knee will be revised into a total knee replacement.
Oh,
you don't, but a total knee goes into if that has to be revised, it goes into a revision total knee, which is again a very major surgery.
Yeah, true. So what are the activities a person can do, like rotational activities like golf, tennis, or marathon, what after rehabilitation period is over?
So, right. So basically, if you even after a total knee, they are able. We don't restrict their activities as such, but yes, running or high impact sports that will affect the joint life, whether it is partial knee or total knee. Golf is again, as you know, it's not a very high impact activity, but say a marathon or any sporting activity that will depend on the age of the patient and how frequently he wants to engage in those kind of activities. Because all said and done, these are, you can say, these are like, good cars. Now, if you have a very good car, but if you keep on driving it on a rough road, then even the best of cars will have, their shelf life is going to decrease. So that will depend on the frequency and all other things like muscle strength and how they are in general. So a lot of people who have been very active stay that way. We just restrict a few of their activities, mainly high impact activities.
Right.
There is one more question I am seeing. Patients who are TKR who get TKR at the age of 60 years. So TKR is advised at this age, or it is beneficial for young one. So yeah, so as I told you, it is more beneficial in the elderly, and 60 is, to be very frank, is pretty young. Okay.
Yeah.
So I would say that the age, if the elder the patient, the better to get a partial knee for that patient, because the complication rate is less. As I told you, he or she has done very well till then with the lateral compartment. So there are no reasons why they would progress for lateral compartment arthritis now after the age of 60.
So
then there is question on age limit.
Yeah.
Right. So yeah, so no age limit as such. We have operated from 42 years. That lady that I showed you was, I think, 44 or something, and we have even operated a 78-year-old person. So there is no age limit as such. But I would, at that age, 44 or 46, I would not want to replace that joint unless, any form of replacement, not even a partial knee, definitely. So I would really want to try doing a stem cells, but stem cells have their own issues now, because the government has some legal issues with procuring stem cells. So at least a platelet-rich plasma for that patient, and give them good physio rehab, a lot of muscle strengthening, bracing if required. And I would not want to replace at a very young age. Forget partially, I would just not want to touch that patient, because all these joints, all said and done, they will require a revision at 20, 25 years. So unless the patient is has a lot of symptoms, a lot of problems, then you need to replace at a young age. And if you are doing it at a young age, you should also know why it is happening. I think that is one common thing. A lot of females have rheumatoid arthritis that is undetected, or other forms of systemic arthritis that is undetected. And these patients, then you should not treat them. Why would a patient get osteoarthritis at the age of 45? So we should think on those lines then. We should think why they are having these kind of symptoms. Is there any systemic problem? A lot of patients also have gout. Postmenopausal gout is also known. So whether it is gouty arthritis, synovitis can mimic arthritis pain, as we all know. So we should get all those things investigated before labeling it as arthritis and going for surgery. Those younger patients would definitely fall into a no surgery group for me, where I would want to, let them go through a lot of rehab and try everything else before I operate on them. So I'll just show you this thing, the model.
We have one more question here.
Right.
Some question. After PKR, can patients go for more progressive? So I guess if we add on to the question, if they can do yoga and meditation and all, or Vajrasan position, what do you say for that? Like we have many.
Yeah, so again, they can do that. The body itself, as you know, there is no, no limit to what your body can do. If they are doing it safely, if there are no symptoms of pain, I think is one of the main symptoms that you should think about. If there's a lot of pain in doing anything, that means there is some problem with the way you are doing it, or the body is still not accepting it. So, but as such, if you are comfortable and you are doing it normally, you were doing it before as well, then you can continue to do it. High impact activities are the only thing I'm a little worried about. But as such, other postures and all are not a problem. They can flex as much as they want to, as much as their body allows to. That is not a problem. Squatting, sitting, cross-legged is fine.
So one more question. Sir, how this PKR behaves in later periprosthetic fractures? Which is the same as the TKR or it
So
should be the different?
that very good question. Partial knee behaves very well, and I'll just show the model here, and I think a lot of things will be clear.
Okay.
You can see this is our total knee. Okay. Now you can see the amount of bone. Is it visible or not?
Yes, sir. Visible. The first model is visible. Second is at the lower level.
Okay. Let me just change. Okay. Now both models are visible.
I can't see anything. There's your photo there. I don't know whether anybody else can see.
Let me.
Yeah.
Now?
Yeah.
Okay.
Yes.
So if you see, this is a total knee replacement. Okay. This is, you can see that, I'll just get it a little closer. You can see that a lot, this is all joint. Okay. So if there's a fracture here, you need to go up to fix it, and the joint will come in between. Okay. You see this? You can see this is the joint, right?
Yes.
Now, this is a partial knee. If you see here, just this portion of the posteromedial femoral condyle is replaced. Actually, the anterior part is where the patella articulates. And since we are not worried about the patella here, we don't need to even touch this part. So now if the patient gets a fracture, there is a very good chance that fixation, we get a very good bone hold here. While in a total knee, we won't have that because there will be a metal there. So definitely in a partial knee, if there is a fracture, if the joint is loose, then we don't have an option. In any case, even in a total knee or in a partial knee, you have to remove that joint. But if the joint is intact and the fracture is somewhere in a different area, then the chances of you fixing that fracture well is much higher with a total with a partial knee because the bone is intact. More bone is left there to fix.
Right.
So do we have some more questions?
So the most popular question asked by patients, cost of PKR versus TKR.
Yes. So initially, before NPPA came, the cost was less. I mean, the cost of partial knee replacement was less. But now the NPPA has come since the last 3 years. So all cost remains the same because everything has been termed in a same group, basically. So it is just whether it is partial or total. If it is cobalt chrome, then the cost is this. If it is, oxenium, the cost is this. So government has just put everything under the same label. So, right. So the cost as such doesn't differ.
So this is for the patient's benefit. PKR
exactly. And it is, frankly, I mean, all of us know that the more articulate the surgery is, it is supposed to be, more costly or more expensive and something like that. The more articulate, like if you go for a microscopic surgery, they are supposed to be more, expensive because you're using those kind of instruments and technology as compared to an open surgery. So similarly, if you look the joint, you might feel that the volume of the joint is less. But again, it is a different technology and that has its own expenses. But now everything is under the same kind of price list. So it is just, there is no difference. It is definitely for the patient's advantage that they undergo this surgery rather than this. Again, as I told you, not all patients of osteoarthritis fit into this category. All over the world, the literature says 35 to 45% of osteoarthritic patients who you can, catch them in that stage, they will benefit with a partial knee replacement. Only 35 to 45. So you can say 3 to 4 out of 10 people who are going to need surgery or for arthritis basically will fit into this category where they can undergo a partial knee replacement. But this option has to be kept in mind, because if you look at even 30 to 40% of the population, that is a huge number per se. And once it is advanced to a certain stage, or they are rheumatoid, or they have some, like a lot of people who have ankylosing spondylitis, they have back issues as well as knee issues. And those patients have systemic arthritis. Those you need to do a total knee replacement. There is no way a partial knee should be done in such patients. Actually, in Bombay or in Ahmedabad, it is very popular. If you might have heard about it, if you speak to physiotherapists in there, it is very popular over there, and patients do very well. It has been going on since years, but somehow here it is still not caught up. The trend is not caught up yet.
There are two more questions in the chat.
When will you? Yes. Okay.
Sorry?
Two questions
So
in the
when
chat.
will you?
Sorry, Sneha, go ahead.
Sir, before that, sir, when will you label the PKR as a surgery failure?
Okay, so if a patient for any cause, okay, for simple things are infection or something like that, if there is infection or persistent infection and all, but if a patient has persistent pain beyond an year, that is a definition of failed TKR. If they have beyond an year, if they have persistent pain, then it has to be investigated thoroughly for like it could be anything. It could be loosening, it could be malalignment, it could be infection, lot of these issues. And if they have even after an year, which I think is a lot, but the definition says it's an year, but even after an year, if they have persistent symptoms of pain, difficulty in walking, or difficulty in day-to-day activities, or difficulty in their normal sitting or normal postures, then definitely I would think that this is a failed knee replacement or a partial knee replacement, whatever.
And the solution is TKR.
No, once it has failed, we need to find out why it has failed. If there is infection, you need to remove everything, give a thorough wash, let the infection settle, then put again a revision joint, which, as I told you, is a big thing where you have to put intramedullary rods and everything. That is the solution, but it has to be done in 2 stages. Yes, you have to do that. But if there have been patients, I have to be very frank, I have even amputated a patient, 78 or 82-year-old lady who underwent a TKR, who had a lot of infection, had gone to multiple places, and by the time she came to us, I really felt that, after undergoing 4 or 5 surgeries, she has been in bed since 1.5 to 2 years. She's not been mobile. Systemic conditions are such. We amputated. We went for an above knee amputation, and the son was in the media. So I was little, I had to explain everything to him. He was little taken aback when I told him that amputation is a option for you. And now, after 3 months of that amputation, that lady has got a good, prosthesis, and she's able to move around, at least do her day-to-day activities, walk and everything, which without any medicines, without any IV lines, without any more surgeries required. So I think, yes, failures have to be treated, and sometimes unfortunate things do happen. But if you look at the success rate for total knee replacement as such, it is more than 90 to 92%, and for a partial knee, it is more than 98%. So yes, there is a failure rate. You guys deal with a lot of patients, and you have seen a lot of patients who would come to you for rehab and even for opinions. There is because once the number of patients increase, you are bound to see some failures. It is like accidents on the road. Once there is a rate of accidents. Once the number of vehicles increase, there is going to be an accident. But yes, you just have to be more cautious. You can't just stop traveling.
Right.
So did I miss some more questions in the chat box? Okay.
Yes,
Patient
sir.
with severe RA and severe muscle spasm with no movement in the knee. Is there any help of knee replacement? Okay. Does the rehab program vary in PKR and TKR? Okay. There is long-lasting TKR or PKR. Okay. So life of the joint, long-lasting. Simple answer: there is no difference in the life of the joint. A partial knee may even last longer than the total knee. Depends on the patient and how we have done the surgery. So there is no difference technically. The second thing was okay. Okay, so with the severe rheumatoid arthritis with severe muscle spasm and no movement. Okay, so those patients who have severe rheumatoid arthritis, they need to be treated medically first. See, in rheumatoid arthritis, you have to understand that there is a lot of synovitis. That synovitis is also a cause of severe pain. So it's not just the bone. So synovium also, that has to be addressed medically. You have to give a lot of these anti-rheumatoid drugs and all. Once everything is under control, the patient is fit for surgery, then you have to evaluate whether how much is the spasm and everything. And if they are fit for surgery, then definitely knee replacement will provide a solution. But we have seen such patients who are severely rheumatoid. They have a lot of cardiac issues related to rheumatoid disease. They also have a lot of muscle weakness. And as you know, the rehab is not, you can't expect them to start walking the next day. Because the muscle spasm, the muscle wasting would be there. They will not have a lot of strength. They have not been mobile. So a lot of issues will happen. A lot of our rheumatoid patients, because of their hand deformities, cannot hold the walker. So all these things do come in the picture. So we can't just label all of them into one group, because so you see a normal patient will start walking the very next day after knee replacement and they'll be very happy. But when a very severe rheumatoid patients comes, you can't tell them that you will start walking the next day. So each patient will be different in how the disease goes and how they will progress. But yes, knee replacement is an option for such patients, definitely. So we have an interesting question. Post ACL reconstruction patients with early OA can be treated with partial knee replacement. That is a superb question. Yes, you can treat as I told you, the ACL has to be functionally intact. If the ACL has been reconstructed and it is functionally doing well, then definitely they are a right candidate for a partial knee replacement. I know a couple of doctors in Pune who if they feel that the patient just has anteromedial arthritis and they are not sure about the ACL, they scope the knee. If they find that the ACL is not very good, they do reconstruction of the ACL. After 3 months, they go for a partial knee replacement. Which, I mean, I don't do that, but they are so convinced about, and they have been doing it since years. It's not like, 1 or 2 years. They have been doing this since years. And they are very happy with doing this, where they reconstruct the ACL. Once the ACL rehab is over, they go for partial knee replacement. So that is there. Some people do it with success. Although personally, I have had no experience with that. So I don't see any more questions.
Sir,
Steven, did I miss anything? Did I miss any question?
No, I think we covered, and people also ask pretty good questions.
Sir, one more question here.
All right.
Sir, a lot of people nowadays talking about this stem cell therapy and PRP and everything. So, sir, what are your experiences regarding how the recovery to the patient that it is a definitive treatment, or there should be some problems in this?
So yeah, a very tight question, I would say, to answer. But see, stem cells per se, there has been a problem with acquiring stem cells, okay, because the government has put a lot of restrictions now. Initially, before 5 to 7 years, there were no restrictions. We used to get the stem cells from the bone marrow or sometimes even from the fat. But now there are restrictions, so I have personally stopped doing stem cells since the last 3 to 4 years. Now I am mainly doing platelet-rich plasma, that is PRP. PRP has got very good results in a short, okay, say I'm talking about my results. In last 2 to 3 years, I have found very good results with PRP. But the main problem is you have to see that there are no other mechanical malalignment, because that is one thing where if the cartilage has started to degenerate, PRP will provide potential for cartilage healing. But if the varus is not corrected either by a brace or a high tibial osteotomy, and you just put a PRP inside, but that stress is going to be there, so that cartilage will degenerate. So you have to evaluate if the mechanical axis is good, if the patient is young, then definitely PRP will extend joint life. How much, till how long is difficult to answer. But as I told you, PRP, there is no loss in doing the PRP procedure. That is one thing. I think what we should always think as surgeons or as any treating physiotherapist, we should not cause any harm to the patient, like steroid injection. Okay, I have seen patients getting steroid injections and getting an ACL rupture post that. That is documented. All right. So steroid injections I would reserve for the very elderly patients or those kind of rheumatoid patients, who surgery is not an option. They are medically unfit. They are not willing for surgery. They want immediate pain relief. Those patients, yes, steroid injections have a role. But PRP definitely, if the patient is right, then and in an early stage where there is not grossly obese, the mechanically well aligned, then PRP will give good results.
So Dr. Kunal, after hearing that, I'm impressed that that's quite ethical practice compared to many people we see.
I think, I would say that there is no other way you can do that, because if you look at what you won't get the results.
Yeah.
Ethics is definitely we have to follow ethics, but the other thing, you won't get the results. Your patients will eventually, they will feel they did not get benefit from getting treated. So that is the thing. I think you're picking the right patient always remains a challenge, and always you need to update yourself to do that, to just pick the right patient. So now, once you learn surgeries and everything, the challenge is, I think, more to kind of to know when to do what rather than how to do it.
Right.
So it is when to do what remains the most challenging. And I'm sure it must be there for you people as well. You just can't have the same modality of treatment or the same thing for each and every patient. It will not work. Your patient will not be satisfied.
Right. Great. Any other questions from anyone?
So okay. I think we'll call it a day then.
Yes. So as we are ending this, it is a time to thank the people who are responsible for this beautiful session, wonderful and informative session. And first of all, I would like to thank all participants who have overwhelmingly responded to this webinar, and they have actively participated, and even they are very active in the question answer sessions. So I think they are very attentive kind of audience. Secondly, I especially thanks to Dr. Kunal Sir, who has spared his valuable Sunday time for all of us. His team, Dhruvi and Jayesh Bhai, I think they are the supporting staff here. So I think we are thankful to them also. And I request sir that time to time we will arrange this kind of informative sessions so that we can increase our knowledge and we can have good exposure of this kind of things, which is new to us. And thank you so much again.
Thank you so much. I would also like to really thank my both moderators, Drashti and Snehal Bhai, for organizing this very successfully, getting a lot of these participants. And of course, the participants have been really very attentive. They have been asking a lot of questions, which is so encouraging for us. I would wish all of you a happy new year in advance. For all those
Same to you,
who have not got COVID, hopefully they don't get it till the vaccines come. And for all those who have got COVID, their antibodies stay till they get the vaccine shot. So I
Right.
think,
Thank you, sir. Thank you.
yes, thank you all of you. Thanks to all of you, and thank you so much for coordinating everything. And yes, hopefully something new. Again, we can meet this way at least, and we can discuss something else. It is always very, good to encourage with a physiotherapy group because they do understand everything very well. So that way, it is always a team effort for us as well. So it's very nice to interact. And again, I hope to really interact again
Yeah.
in some
Most
way.
welcome, sir, and thank you.
Thank
Most
you.
welcome.